Okay. All right. Hi, my name is Christy Higgins. I'm a PGY1 pharmacy resident, and I'm going to be talking today about hormonal contraception. So, the objectives for this presentation are to describe indications for estrogen and progestin containing contraceptives, to identify long acting contraceptives and explain their place in therapy, and to recognize appropriate use of emergency contraceptives. So, I wanted to start with a little bit of the history of contraception. So, Egyptians are recognized as one of the first civilizations to use birth control. So, ancient drawings as early as 3000 BC depict men wearing condoms. Egyptians also developed many of the early contraceptive strategies, such as vaginal pessaries or sponges. In 4th century BC, Aristotle was the first Greek writer to mention contraception. In the 16th century in Europe, condoms were first used to prevent syphilis and then to prevent pregnancy. So other than condoms, the main birth control methods prior to the 20th century were abstinence, interruptions in sex, breastfeeding, and induced abortion. In 1957, the first hormonal pill called Envoid was approved by the FDA as a treatment for menstrual disorders. The initial dose of estrogen contained in the pill was very high. It had a high contraceptive efficacy, but there were also a lot of side effects. So in 1961 was the first reported death of a woman from thrombosis from taking the pill. So 6 deaths and 20 non-fatal cases in a year were reported. So the dose of estrogen has been decreased over the years in birth control pills to decrease the cardiovascular risk associated with taking the pill. In the 1970s, the concept of using a natural 17-beta estradiol in combined pills arose, and also in the 1970s, progestin-only pills were developed. Injectable pills and long-acting reversible contraceptives were developed in the early 1990s, and then in the 2000s, their popularity has really grown, and that's kind of more what we're familiar with today. So I think it's important to briefly review the menstrual cycle to really understand how contraceptives work. I don't know if you're able to see my mouse here, but the gradually increasing amount of estrogen in the follicular phase causes discharges of blood flow to stop and the lining of the uterus to thicken. The follicles in the ovary begin to develop under the influence of a complex interplay of hormones. So approximately mid-cycle, there's this surge in luteinizing hormone, and 24 to 36 hours after this surge is when follicles will release an ovocyte, which is an event called ovulation. So after ovulation, the ovocyte lives for about 24 hours or less without fertilization, and so the remains of the dominant follicle in the ovary become the corpus luteum. And this corpus luteum produces large amounts of progesterone. So under the influence of progesterone, the uterine lining changes to prepare for a potential implantation of an embryo to establish pregnancy. So if implantation does not occur within approximately 2 weeks, the corpus luteum will involute, and this causes sharp drops in both the levels of progesterone and estrogen. So now we're going to get into some oral contraceptives. So there are 2 types of oral contraceptive pills. There's combination pills that contain both estrogen and progestin, and then progestin-only pills. Combination pills are packaged in either a 21-day or a 28-day regimen. And the rationale for this is to mimic the average cycle length of 28 days. But you can shorten the hormone-free period to less than 7 days. So there are pills that contain 24 days of active pills with 4 days of placebo, which would make the hormone-free period shorter. And then there are also continuous cycle oral contraceptives that eliminate the hormone-free period entirely. So every pill is considered an active pill. And combination pills come in 2 different types. So there's monophasic pills, which have the same strength of estrogen and progestin throughout, and then multiphasic pills, where the strength of estrogen stays the same, but the dose of the progestin changes throughout. Some just directions for these pills. You can start taking them on the first day of the period, which does not require any backup contraception. This is not as commonly done most physicians will recommend patients start the Sunday following their period, and this does, on the initial start, require backup contraception for 7 days. So there are a few different types of estrogen and progestins that are present in combined contraceptive pills. The most common component of estrogen is this ethinyl estradiol, and this is present in about 98 to 99% of birth control pills. So the role of estrogens in birth control pills are to suppress the follicle-stimulating hormone secretion and to inhibit that surge of luteinizing hormone. By inhibiting the surge of luteinizing hormone, this is the most important aspect to make sure that ovulation does not occur. The role of the progestins are to slow tubal motility, delay sperm transport, induce endometrial atrophy by making it unfavorable for implantation, and to thicken the cervical mucus that slows sperm transport. So kind of looking back at our menstrual cycle and putting this together, inhibiting the surge in luteinizing hormone by the estrogen component is one of the most important aspects to ensure that ovulation does not occur. There are some risks that are associated with estrogen therapy, and they depend on the type, the dose, and the route of administration of estrogen, as well as some patient-specific factors. So lower doses of estrogen are associated with reduced risks of thromboembolism, but they may have higher associated risks of breakthrough bleeding because it might not be enough estrogen for the woman to prevent this. Smoking, older age, so age greater than 35, hypertension, and migraine headaches, specifically migraine headaches with an aura, can be patient-specific factors that put patients at a higher risk of complications like thromboembolism from estrogen therapy. There are some other dosage forms available for patients who do not want to take oral contraceptives. So Xulane is a transdermal patch that contains both estrogen and progestin. The patch is worn for 1 week. It's changed weekly for 3 weeks, and then it's followed by 1 patch-free week. There is a warning associated with this patch because there's a higher exposure to estrogen, so this may put patients at a higher risk of those thromboembolic complications. The NuvaRing is a contraceptive ring that's placed intravaginally. 1 ring is worn for 3 weeks and then removed for the 4th week. This is not the best option for everyone. Not all women are comfortable with it. It's also important to note that if the ring comes out for greater than 3 hours, then women would need to use backup contraception as well. So there are also contraceptive methods that are progestin only, and these are good options for women who cannot tolerate the estrogen therapy. They may have specific effects that might contradict them from being able to receive estrogen. So the progestin-only pills do not have an effect on coagulation factors, blood pressures, or lipids. However, these pills may be associated with more breakthrough bleeding than the combination pills. They may cause depression, and they can also have a variable return to fertility once women decide to stop taking them. So backup contraception is not necessary if the progestin-only pills are started within the first 5 days of menses. Because of its short duration of action and the short half-life of the progestin-only pills, it's really, really important that women take it at the same time each day to maximize the contraceptive efficacy. So if the pill is taken more than 3 hours late, it can actually put women at an increased risk of not having the same efficacy of the pill. And so in that case, they would need to use backup contraception. So just some indications for the progestin-only contraceptives, kind of similarly to what would be associated with risks of estrogen therapy, but the migraine headaches, age greater than 35 years, a smoker or obese, history of thromboembolic disease, cardiac disease, cerebrovascular disease, early postpartum period, so they can be used within the first 6 weeks postpartum. These are commonly used for women who are breastfeeding. hypertension with vascular disease or older than 35 years, lupus with vascular disease, nephritis, or antiphospholipid antibodies, or hypertriglyceridemia may be all indications for progestin-only contraceptives. The Depo-Provera is an injectable progestin-only contraceptive. Oops. It should be initiated within 7 days of the onset of the last menstrual period. Subsequent injections are given every 3 months. It may cause menstrual changes or unscheduled bleeding during the first few months of use. Can also cause weight gain over time, and long-term use may affect bone density. So like I mentioned, subsequent injections are given every 3 months, and it's important that this medication is initiated within 7 days from the onset of the last menstrual period. So now I'm going to move on to some long-acting reversible contraceptives. So long-acting reversible contraceptives, also sometimes referred to as LARCs, are the most effective reversible method of contraception once they've been inserted, and they do not require, for the most part, regular action by the patient. They're considered one of the first-line options for adolescents by the American College of Obstetricians and Gynecologists. So Nexplanon is an implantable rod that's placed under the skin. It's effective for 3 years. It has a low failure rate and has no estrogen side effects. Return to fertility can occur within 6 weeks of taking out the rod. Some disadvantages of the Nexplanon: it does require insertion and removal by a physician. It can be felt under the skin, which can be uncomfortable for some people. It can also cause menstrual irregularities, and it's not been well studied in obese women who are greater than 130% of their ideal body weight, so it may not be a good option for these women. There are also multiple long-acting reversible contraceptives that are placed in the uterine. Progestin-only IUDs like Kyleena, Liletta, Mirena, and Skyla have advantages. They can reduce menstrual bleeding and anemia. They can also cause reduction in dysmenorrhea, and they have also helped with endometriosis-related pelvic pain. So there's also a copper IUD. This one has some advantages as well. It avoids exogenous hormones, like the progestin or the estrogens, which may be helpful for some women who need to avoid hormones. It does not cause amenorrhea, so for women who still want to have a period, it could be a good option for them. It can also be placed for 10 years, which can be a good option for some women as well. And then this can also be used as an emergency contraceptive option. Some disadvantages of the long-acting reversible contraceptives. So they don't require regular maintenance, but some women do still have to women should still perform monthly string checks to make sure that it's still in place. Some women may not be comfortable with this. It does require insertion by a physician. Patients may experience irregular bleeding initially. Some contraindications to receiving these treatments: patients who have uterine anomalies, a current or history of pelvic inflammatory disease, or undiagnosed uterine bleeding would not be good patients for the long-acting reversible contraceptives. So now I want to move on and talk about emergency contraceptives. So emergency contraceptives refer to the use of drugs or a device as an emergency measure to prevent pregnancy. So women who have had recent unprotected intercourse, including those who have had a failure of another method of contraception, are potential candidates for this intervention. So the mechanism of action of emergency contraceptives depends on the timing of administration in the menstrual cycle. So when in the menstrual cycle this happens. They can be known to inhibit ovulation, impair endometrial implantation of a fertilized egg, cause changes to the cervical mucus, and then also can cause alterations in transport of sperm, egg, or embryo throughout the reproductive tracts. So there are a few different options for emergency contraceptives here in the United States. So levonorgestrel, or Plan B, it is a 0.75 milligram dose that's given twice, 12 hours apart, or a 1.5 milligram dose given once. So it can be used up to 3 days or 72 hours after unprotected sex, and has a reported efficacy of 59 to 94%. Some side effects associated with it: it may cause menstrual changes, nausea, abdominal pain, tiredness, or headache. And if a patient vomits within 2 hours of taking the medication, they need to contact their doctor. Estrogen plus progesterone. So there are no FDA-approved products, but they can take excessive amounts of commercially available birth control pills. So 100 to 200 micrograms of ethinyl estradiol plus 500 to 600 micrograms of levonorgestrel 12 hours apart. And these are found in some commonly used birth control pills, but you would have to take multiple of the pills to get this effect. Can be used up to 5 days or 120 hours after unprotected sex, and it is reported efficacy of 47 to 89% of pregnancies were prevented. The copper IUD, if inserted within 120 hours of unprotected sex, can be effective, so up to 5 days, and this one has one of the higher efficacies of up to 99% of pregnancies prevented. And then ulipristal, or Ella, is a single oral dose of 30 milligrams, can also be used up to 5 days after unprotected sex, and has a reported efficacy of 98 to 99%. Some adverse effects that are associated with Ella: it can cause headache, abdominal pain, nausea, dysmenorrhea, and again, if the patient vomits, they need to contact their doctor if they vomit within 3 hours of taking the medication. All right, so now I'm going to move on to the assessment questions. So which of the following increases the risk of complications in patients who are taking estrogen therapy? Is it smoking, hypertension, migraines, or all of the above?
D.
Yes, D, all of the above. So which of the following patients would not be a good candidate for progestin-only therapy? So a young female in the early postpartum period, gave birth 6 weeks ago. A young healthy female who's not good at remembering to take her pills. A woman who is a smoker who's over the age of 35, or a 26-year-old woman who has a history of thromboembolic disease. So someone who is not a good candidate.
C.
It was actually B, because, and the reason for this is because you have to take the pills so regularly, and if you miss them by just a few hours, then they're not as effective. So in someone who's not good at remembering to take their pills, it's probably not the best option for them. And I should have clarified that this would be progestin-only oral therapy. They may be a good candidate for the Depo-Provera shot. So which of the following is a long-acting contraceptive method, or the LARC? Is it NuvaRing, Kyleena, Seasonique, or Plan B?
Yes. Forget. Either B or C.
It's B, Kyleena. So C is one of the actual 3 months of the oral therapy. But one of the long-acting reversible contraceptive options is Kyleena. All right, that's it.
And expected, leading to complications from maybe like overdose on those hormones?
Not that I'm aware of. I have not heard of that being a risk. It is still the progestin only, so it's not that you don't have the risk with the estrogen like that you would have with estrogen. But I have not heard of them causing like a depot effect where they would get like too much hormones at once.
How did they actually regulate the constant release? Would that be something you studied in this?
I did not study that for this. I mean, just kind of thinking back towards like, other things that release in that sort of manner, that it's just kind of a prolonged, keeps things kind of constant. So I wouldn't expect them to like over release hormones. Yeah, but I'm not super familiar with that.
Um, and or is
Yeah.
that the case? Or?
I'm not actually sure if that is the case because you don't need parental consent for like oral contraceptives. So because it's a procedure that might be, even though it's a minor procedure, I mean, it's something that they can just do at the doctor's office. That might change things a little bit for those who are under the age of 18. So I'm not 100% sure if they would need it, but I know like for oral contraceptives, you don't need parental like permission for them. So I would kind of think this falls under the same like category as that. Yeah, but that is a good question. I'm curious about that because it is technically considered a procedure, but.
In just different studies
I
results?
I think user error is probably one piece of it. It could also depend on when in their cycle they take it. So people who are taking it within like the first maybe couple days of their menstrual cycle would have a different effect than someone who's taking it, in the middle where they would be more likely to be ovulating. But I would think even still taking it appropriately, that they should still have the effect from it. But I think that variation probably comes from where in their menstrual cycle they're taking it, how recent from unprotected sex they take it. So did they take it the next day or was it a few days later? I would think that the reported efficacy, they probably get all sorts of different people who took it differently. Yeah. These are good questions.